Hello and welcome back to the Biochemistry for Health Sciences channel. In today's video, we shall discuss the relationship between sodium and water. In the last video 9.19, we discussed a topic related to sodium, and that was the topic on sodium taste receptors. In this video, we'll see this very close relationship between sodium as well as water. Just as a reminder, we did discuss a little bit about the biochemistry of water in video 2.01, osmolarity and osmolality in video 2.02, and tonicity in video 2.03. So these are some of the definitions that are important for you to understand before we can totally appreciate hyponatremia as well as hypernatremia. So let's go through some of these definitions. Osmolarity is the number of osmoles, or OSM or OSMOL, of solute. That's per liter. That's a volume of solution. A related definition is osmolality, which is what we are going to use in future videos. This is number of osmoles of solute, so same thing, but per kilogram, not liter, but kilogram, not solution, solvent. Okay, so in body, of course, the solvent is water. So this is what we will use, osmolality. So we can calculate osmolality using the Wortley equation. So the serum osmolality is calculated using this formula: 2 times concentration of sodium plus the concentration of glucose plus the concentration of urea, if all the units are in millimolar. Now, the reason why we have this 2 here for sodium is because sodium doesn't exist by itself. It always has an associated anion, and this anion most often is chloride, but it could be bicarbonate or something else that could also contribute to the osmolality. Now, in some countries, including the United States, we do not report glucose as well as urea in millimolar. We use milligrams per deciliter. So we use milligrams per deciliter. In that case, this formula is modified slightly. The serum osmolality is 2 times sodium. Sodium is always reported in millimolar, but the glucose should be divided by 18, while the urea should be divided by 2.8. And that will give us the serum osmolality. Now, the reference range for serum osmolality is around 275 to 295 milliosmoles per kilogram. So here's an example of how we could calculate a patient's serum osmolality. So we get the concentration of sodium, multiply by that by 2. So the sodium concentration is 137 multiplied by 2. We get the concentration of glucose. The glucose concentration here is 188. Divide that by 18. And then we have the concentration of urea, BUN, blood urea nitrogen. That's 15. 15 divided by 2.8. And we get 274 for sodium. You can see this is a huge number compared to 10 for the glucose part, 5 for the urea part. Add all that up to give you 289, which you can see falls in the reference range. So you can see from this example that sodium, that's a huge number here compared to the other two, plays a very, very important role in serum osmolality. So it's not surprising that sodium and water are very closely associated. So for example, if there is high sodium outside, that means the osmolality will be higher outside in the bloodstream, let's say, compared to inside the cells. And if the osmolality is higher outside compared to inside the cells, water will always go from a low osmolality, in this case inside the cell, to a region of high osmolality, in this case in the bloodstream. So the water will follow the sodium. The reverse case, if there is very little sodium, low osmolality compared to inside the cell, then the water is going to go where there is more sodium. So in this case, more, let's say, inside the cell, the osmolality is higher. So the water is going to go to where the sodium is. So in the first case, when water leaves the cell, you can see the cell is going to shrink in volume. And for most cells, this may not be a problem, but for neurons, it may be a problem, and we'll see that in future videos. And in the reverse case, if water enters cells, then the cell is going to swell, it's going to increase in volume. And again, this is going to be a huge problem for neurons, especially the ones in the brain, because the brain is surrounded by a skull. And so there's really not much space for neurons to increase their size in the brain. So we'll see this very important problem that leads to various symptoms when we discuss hypo as well as hypernatremia. So since water is closely related to sodium, let's discuss the life story of water, the absorption, distribution, metabolism, and excretion of water. So first, the absorption or the origin of water. Where does the body water come from? The diet gives us about 2 liters per day. Secretions in the GI tract, that's about 7 liters a day. Metabolism can give us a little bit of water, okay, about 0.3 liters per day. So this is where our body water can come from. So how is water absorbed in the GI tract? There is a transcellular pathway. So you can see that these cells that line the GI tract, they have these sodium-potassium pumps that keep the concentration of sodium very low in the cytoplasm. And so sodium from the outside, from the diet, from the GI cavity, can easily enter the cells. And remember, water follows. So this water is also going to enter the cell because the osmolality here is higher, right? The osmolality here is higher compared to the GI cavity. So water is going to enter the cell. So one way the water enters the cell is called transcellular. It goes through the cell membranes, but water cannot directly go to the cell membrane very well. It needs a protein. These proteins called aquaporins, which we'll come across a lot in the future, such as AQP1. So there are different types of aquaporins. So the water can enter the aquaporins and enter the cell and then get out of the cell into the serum. So that's called the transcellular. Water can also go through paracellular, that is between the cells of the GI tract. So in this case, the water from a lower osmolarity is going to get into the bloodstream where the osmolality is higher. Distribution, well, water is the solvent. Remember, it's a liquid at room temperature as well as body temperature of 37 Celsius. As mentioned, water travels from low osmolarity to high osmolarity. And since sodium is the most important, has the most important effect of osmolality, as we discussed and explained earlier, water follows sodium. Now, most of the water is found inside cells, intracellular. that's about 67%. So if the total body water is about 42 liters in an adult, we are talking about 28 liters, 67% of 42, 28 liters inside the cell. In the interstitial fluid between the cells and the bloodstream, we have about 25%, that's about 10.5 liters. And the least amount of the water, about 8%, is found in the bloodstream, that's about 3.5 liters. So water can be distributed very rapidly. You can see the water in the bloodstream can go across into the interstitial fluid and then can be taken up by cells to go inside cells. So this part is rapid. This is slightly slower, takes a few minutes. There is another place where we do have water. We call it the third space. This is the pleural and peritoneal space. Has very little water, about 50 mils. That's about 0.05 liters. So in future videos, we will just basically ignore this and we will focus mostly on intracellular, interstitial, as well as the bloodstream. So just to give you an example, what would happen if we drank, let's say, 1 liter of water? So we have 42 liters total. We drink 1 liter, that's 1,000 mils. We will end up with a total of 43 liters. So how is this 43 liters going to be distributed? Let's look at this. So the 1 liter, 1,000 mils will that you drink will be absorbed into your bloodstream, and there 8%, that's about 80 mils, will stay in the bloodstream. 25% will stay in the interstitial fluid, okay, as water is distributed, and most of the water eventually will end up 67%, that's 670 mils out of that 1,000 mils will end up inside the cells. Okay, so you can see if you drank 1,000 mils of water, 80 mils will be in the bloodstream, 250 in the interstitial fluid, 670 will be inside the cells. Now, if the solid concentration is not affected, you just drank pure water, then what will happen if your osmolality was 280 in the bloodstream and you drank 80 and there's 80 mils of pure water, that's going to reduce the osmolality to 274. How do you get this number? 280 times 3,500, that's the original volume of water, and now you added 80 mils, that will be 3,580, so 280 times 3,500 divided by 3,580 will give you 274. You do the same thing here. Now you have 250 mils. It should give you the same amount of osmolality. So in a healthy person, all of this should be the same. Okay, so the osmolality will equilibrate and come out to be the same as water distributes to the different parts of the different compartments in the body. Metabolism, well, water is used in a lot of reactions that we discuss in metabolism. One important thing is the generation of energy, remember, happens in the electron transport chain, oxidative phosphorylation. A lot of oxygen here that we breathe in is used here, and a lot of hydrogens that are coming out from food stuff, all the fuel molecules are entering the electron transport chain, and one of the products that we get here is water. So we produce about 0.3 liters of water per day, most of that right here in the electron transport chain. When we discussed this central pathway of glycolysis and then the PDH reaction and the Krebs cycle, and then eventually to the electron transport chain, oxidative phosphorylation. Okay, so we do get water from metabolism. Now, this water from metabolism is very important for example, for animals that live in deserts such as camels. So that's why they store a lot of fat in their hump, because the metabolism of the fat is going to release a lot of this water, and therefore they can survive for long periods of time without drinking water. Okay, so let's look at the E part of ADME, excretion. How is water eliminated or excreted? Feces, about 5%. Respiration through lungs, about 10%. So this we don't even know this is happening, so we call this insensible loss of water just by evaporation. Sweating, skin sweat, 10%. Most of the water, not surprisingly, is eliminated by the kidneys, 75%. So how is water excreted by the kidneys? Well, the fluid, basically everything, all the small molecules plus water will be filtered. Then in the proximal convoluted tubule, about 70% of the water will passively follow the reabsorption of solutes such as sodium. And this water will travel through aquaporine channels. In the descending limb of the loop of Henle here, in the descending limb, about 20% water will be reabsorbed because there's a high concentration of sodium, especially in the medullary part of the kidneys. High concentration of sodium will allow this water to be reabsorbed out of the tubules. The ascending limb, this part here, this is impermeable to water, so nothing happens to water here. Now here in the distal convoluted tubule and the collecting duct, this is very important for water regulation and for understanding hypo as well as hypernatremia. So here we have two very important hormones. One of them is antidiuretic hormone. Antidiuretic hormone. This is responsible for reabsorption of water from the collecting duct as well as the distal convoluted tubule. And what this hormone does, it basically regulates, it adds the aquaporine channels to the cells. Okay, so it either increases the amount of aquaporine channels or increases the activity of aquaporine channels. And by doing that, more and more water can be reabsorbed out of the tubules into the bloodstream. So antidiuretic hormone plays a very, very important role in water and therefore in hypo and hypernatremia that we'll talk about in future videos. Very, very important. Antidiuretic hormone, also called vasopressin. Okay, so do not forget this name. Another hormone is aldosterone. Aldosterone. Okay, and we'll talk about this in the future too. This is part of the system that we'll talk about, another very important system called the renin-angiotensin system. Aldosterone stimulates the reabsorption of sodium in the distal convoluted tubule as well as the collecting duct. So as sodium gets reabsorbed, remember water will follow? Water follows sodium. So water will also get reabsorbed. Okay, so aldosterone, so antidiuretic hormone and aldosterone, two very important hormones that we'll discuss, and these are very important to understand hypo and hypernatremia, why our blood sodium goes down or why our blood sodium goes up. Okay, so hormones will play a very important role later when we talk about hypernatremia. Just to summarize, antidiuretic hormone or vasopressin that comes from the pituitary gland causes increased water reabsorption. In other words, decreased water excretion. Okay, so when we say increased water reabsorption, that means decreased water excretion. Aldosterone that comes from the adrenal gland, that will cause increased sodium reabsorption, which will cause increased water reabsorption because water follows sodium. So once again, decreased water excretion. Okay, so these two hormones decrease water excretion. And then we have one more hormone, or hormones, a class of hormones called cardiac natriuretic peptides. There are two important ones, ANP and BNP. These two, the opposite. They increase sodium excretion, which means they increase water excretion. Okay, so opposite of ADH and aldosterone, they cause increased water excretion because they increase sodium excretion. Okay, so that's a little bit about this very close friendship between sodium and water. In the next video, we are going to now start laying more and more foundations to understand hypo and hypernatremia. And this one here is very, very important. We will see how low blood volume, what we are going to call as effective arterial blood volume, or EABV, how this is going to affect the life story of sodium and water in your body. And this is going to be very important to understand hypo as well as hypernatremia, why your blood sodium goes up or why your blood sodium goes down. Okay, so until the next video, once again, thank you very much for watching and supporting this channel. Have a wonderful day, and we will see you soon.